This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending here, and I'm joined today by our research fellow.
And I'm Dr. Alara. Today we're looking at a fascinating new study from the journal World Neurosurgery, 2026 edition, titled Investigating Prognostic Factors for Primary Endoscopic Third Ventriculostomy in Adults and Elderly Patients with Non-Communicating Hydrocephalus.
This is a timely topic, Alara. We've been performing endoscopic third ventriculostomies, or ETVs, for decades now. It's a well-established treatment for obstructive hydrocephalus, primarily because it offers what we all want for our patients, durable cerebrospinal fluid diversion without the long-term risks of shunt dependency. No hardware, no valve adjustments, and hopefully no infections.
Exactly. But the challenge we often face in the clinic is predicting who will actually benefit. For our younger patients, the path is relatively well-trodden. We have the ETV Success Score, or ETV-SS, and we look for specific radiological signs like third ventricle bowing. However, as this paper points out, while these factors are validated in pediatric cohorts, their predictive value in adults and especially elderly patients remains unclear.
And that's the crux of the clinical dilemma. When you have a 75-year-old with non-communicating hydrocephalus, can you rely on a scoring system built largely on pediatric data? The pathophysiology of the aging brain, the compliance of the ventricles, and even the etiology of the obstruction can be quite different from what we see in a newborn or a child.
That's what the authors really dive into here. They are investigating prognostic factors specifically for this older demographic. They looked at patient age, etiology, the traditional ETV-SS, and those radiological signs of third ventricle bowing to see if they hold the same weight as the patient ages.
Let's talk about that bowing for a second. For the residents listening, when we talk about radiological signs of third ventricle bowing, we're looking for evidence of high-pressure dynamics, the floor of the third ventricle bulging downward, the lamina terminalis pushing out. In the pediatric brain, that's a classic sign of an obstruction that's likely to respond well to a fenestration. But in an elderly patient, where you might have comorbid atrophy or different elastins, that bowing might not be as pronounced, or it might mean something else entirely.
Right, and the study questions if that bowing remains a reliable predictor in the elderly. The authors note that the durable cerebrospinal fluid diversion we seek is contingent on these factors. If we use the wrong criteria to select adult patients for ETV, we might be setting them up for failure and a secondary procedure for a shunt anyway.
It's interesting that they focused on primary ETV. We're not talking about ETV as a salvage procedure after a shunt failure, but as the first-line surgical intervention. For a neurosurgeon, the goal is to avoid the shunt treadmill. But to do that safely in adults, we need to know if age itself is a contraindication or just a variable we need to weight differently.
The emphasis on the paper is that while etiology is a major component of the ETV-SS, the way it interacts with the aging brain is a gap in our current knowledge. We know that in kids, post-infectious hydrocephalus has a much lower success rate than aqueduct stenosis. The question this study raises is whether an adult with a late-onset stenosis has the same physiological success profile as a 10-year-old with the same diagnosis.
And that's why this research in World Neurosurgery is so critical. We need to refine our selection criteria. If the ETV-SS isn't the gold standard for the 60-plus population, we need to know what is. Is it the degree of ventriculomegaly? Is it this specific etiology? Or is it a combination of radiological markers that we haven't fully codified for adults yet?
It really comes down to personalized medicine in the OR. We want to offer the most durable solution. If the predictive value of these factors is unclear, as the abstract suggests, then we are essentially operating in a gray zone when we treat the elderly.
Well, this study is a great step toward clearing up that gray zone. For the residents and students listening, the takeaway here is to look closely at your preoperative imaging, check that third ventricle bowing, but also keep a critical eye on the literature. We can't always export pediatric success metrics into the geriatric population.
Definitely. It's a reminder that neurosurgical prognosticating is an evolving science.
Absolutely. Well, that's all the time we have for this deep dive. Thanks for joining us on the Neurosurgery Hub podcast.
We'll see you in the next episode.